Rajesh sir, good evening, sir. Sai Krishna sir, good evening, sir.
Sir, good evening, sir.
Sir, Sai
Sir,
sir, we are
good
unable
evening,
to
sir.
hear you, sir.
Good evening, sir. Can you hear me now?
Yeah.
No.
Yes, sir.
Rajesh sir, good evening, sir.
Sir, good evening, sir.
Rajesh, sir, good evening, sir. I'm Dr. Prabhakaran from Chennai, sir.
Good evening, sir.
Sir, good evening, sir.
Krishna Patel, sir. I'm Dr. Prabhakaran. Good evening, sir.
Good evening, sir.
Lavnish, you can share your screen.
Yes, sir.
Sai Krishna sir, are you okay, sir?
My screen visible, sir?
Yes, yes. Give me a moment. I think Dr. Sai Krishna has some challenges.
Yes, sir.
Lavnish, Chief Madam is joining, ma?
Yes, sir. One second.
Maybe you can give a call to her house if she's joining. I
Yes,
have
sir.
sent a reminder.
Yes, sir. I clear the call, sir.
Sai sir, are you okay, sir?
Am I audible now?
Sir, perfect, sir. We are
Hello?
not able to see you, sir.
Connects, am I audible now?
Pakka, sir. You are audible well. Please switch on your video, sir, if possible.
Hello? Connects, am I audible now?
Sir, we are able to hear you well, sir, loud and clear.
Am I audible now?
You are
Yes,
audible,
sir.
sir.
You are audible,
Yes,
sir.
sir. Perfect, sir.
You can hear me? I can't hear you.
Sir, I request you to remove your headset. That is, switch off your Bluetooth, sir. There is some mismatch in the mic, sir.
Dr. Lavnish Kumar is presenting.
Yes, ma'am. Good evening, ma'am.
Yes, ma'am. He is a postgraduate from Institute of General Surgery at Madras Medical College, ma'am. Ma'am, I'll introduce, ma'am. Give me a moment, ma'am. I just the technical
I'm
challenge.
just muting. I'm muting, sir. I have a bit of cough. I'll unmute after some time.
Is that audible, sir? Sai, sir?
Yes, sir. I will. Audible, sir.
I think all of others are fine. Probably some update challenges or version challenges, Dr. Sai Krishna has faced.
I will take it.
Professor Gayatri, ma'am. Good evening, ma'am. Thank you for joining today. Good evening, ma'am. Ma'am, you are in mute mode, ma'am.
Okay, okay. Good evening,
Now
colleagues.
we are.
Good evening,
Yes, ma'am.
all.
Good evening. Good evening, ma'am. We are just waiting for Sai. He has some challenges, ma'am. Give me a moment for it.
Okay, okay.
Goitre madam. Good evening,
Oh,
madam.
sir, Prabhakar sir. Good evening. வந்துருச்சா phone? Auto வந்துருச்சா? Auto வந்துருச்சு. Video. Video ஆன்ல இருக்கு.
Then, I think Dr. Sai has some more time to get back to the meeting. But as a matter of fact, with respect to all of the others, we'll start the session. Good evening, friends. Warm welcome to this edition of the Postgraduate Clinics. I'm happy to share that this is the 318th session we are doing. And so far, 592 cases have been discussed and they are available in the YouTube. First of all, thanks and gratitude to all the senior professors across the country and permitting their postgraduate residents to present a case for the benefit of others. Thank you very much. And in fact, I should put on record the efforts taken by Gayatri ma'am. I requested only yesterday evening, and then she was kind enough to get the candidate ready. And she has taken all the efforts to check the slides and revise the slides for the quality of the presentation and the I helped the student also to become prepared. Thank you, Gayatri ma'am, for joining this evening. I have the presence of very famous endocrine surgeon, the past president of the Indian Association of Endocrine Surgeons, Dr. Sai Krishna Vittal. He is the teaching faculty at Apollo Hospitals, Chennai. We have very professor and head of the department, Professor Radha Verma from NYT Institute of Medical Sciences, Raigad, joining. And Professor Prabhakar sir, again Professor of Surgery at Chettinad Medical College, joining. Thank you, Lavnish, for volunteering to present today. And we have our own eminent faculty, Professor Rajiv Sahai sir, and others who are expected to join us shortly. Thank you very much. And Lavnish, please introduce your unit chief, your director ma'am, and then start your presentation. I request the faculty to kindly take over. Thank you very much. Good luck, Dr. Lavnish.
Thank you, sir. Good evening to all esteemed professors present here. It's an honor to be presenting among you. My name is Dr. Lavnish. I'm a postgraduate from Institute of General Surgery from Madras Medical College. My unit chief is Professor Dr. S.J. Lakshmi, and our director, secretary, is Dr. Gayatri. Again, I'd like to thank Dr. Gayatri for giving me this opportunity. I'd also like to thank all the professors from our institute, Doray sir, Professor Dr. S.J. Lakshmi, Professor Dr. Nanda sir, Professor Maravina, Professor Dr. Kalpana ma'am, and Dr. Manigalan sir. I also like
Next, am I audible?
I'd also like to thank my assistant professors.
Dr. Kanagvel, am I audible?
Yes, sir, you are
Dr.
audible, sir.
Okay, thank you.
Right. Vittal, sir, you are audible, sir.
Yeah, thank you.
All right, sir. Good
Welcome,
evening,
sir.
sir, Vittal, sir.
Good evening. I'm sorry for the inconvenience.
No problem, sir.
Yeah.
Lavnish, go ahead. Yeah.
I'd also like to thank my assistant professor, Dr. Vikas sir, Dr. Kadari sir, and Dr. Vijay sir. Moving on to the presentation. Can I start, sir?
Yes.
Thank you, sir. A 50-year-old female from Chennai presented to the OPD with chief complaints of swelling over the neck for the past 1 month. The patient was apparently normal 1 month back, after which she noticed a swelling over her neck incidentally, which was initially small in size and has progressed to its current size. Patient has no complaints suggestive of compressive symptoms, that is, no complaints of voice change, no complaints of discomfort or difficulty while swallowing, and no complaints of breathlessness. Patient also has no complaints of pain or swelling. Patient also has no complaints suggestive of hypothyroidism, and patient also has no complaints suggestive of hypothyroidism. Patient has no complaints of bony pain anywhere in the body. Patient has no complaints of jaundice. Patient has no complaints of cough and hemoptysis. Patient has no complaints of headache or any convulsive episodes. Past history. Patient is a known case of type 2 diabetes mellitus on insulin treatment. Patient also had undergone an open hysterectomy 20 years ago in view of abnormal uterine bleeding. Patient is not on any thyroxine supplementation or any anti-thyroid medications. Patient is not a known case of hypertension, asthma, CAD, or cardiovascular disease, cerebrovascular disease. Patient also has no history of irrigation to the neck or chest in the past. Obstetric history, T2, L2, all normal vaginal delivery, and last childbirth was 25 years ago. And menstrual history, patient is a post-hysterectomy status. Personal history, patient consumes a mixed diet, no adverse social habits. Patient consumes iodized salt. Patient has no excessive intake of goitrogens, no history of altered sleep pattern. Family history, patient has no history of similar illnesses in the family, no history of any malignancies also in the family. Summary, a 50-year-old female presented to the OPD with complaints of swelling over her neck, which she noticed 1 month ago and has been progressively increasing since then. She also has no other swelling, no other swellings in the neck. She is also a known case of type 2 diabetes mellitus on insulin treatment. She has also undergone an open hysterectomy 20 years ago.
Lavnish, can you show me the picture of the patient that is swelling? Are you having that?
Before that, can we ask
yes, sir.
can be history? Shall we go back to the initial slides? I didn't want to interrupt.
Go to the first slide.
First slide.
Yes, sir.
First slide. Yeah. Sorry, the second one. Okay. These are just cosmetic changes I'm trying to bring. You presented very well. But when you say no complaints suggest of compressive symptoms, you should stop with this. You should not say that is complaints in voice change. That is, you understand? Because sometimes you may forget some of the compressive symptoms and then they'll ask you about that. So you just say the patient has no complaints suggestive of compressive symptoms and you stop over there. Suppose the examiner asks what are the compressive symptoms you ask for, then you would elaborate. It is like saying if somebody asks you how many causes of cyanosis you know, sir, I know 10 causes of cyanosis. You will say 6 and forget the remaining 4. So you don't enumerate all. Let the examiner ask you. Why do you ask for complaints of pain in this patient? May I know?
And some pain can be suggesting a thyroid swelling when if an acute pain usually occurs in case of any hemorrhage into a cyst, and a large goiter or large swelling can also cause pain because of stretching of the fascia. And pain can also be seen in some forms of thyroiditis, that is recurrent thyroiditis.
Yes, yeah. Large goiters, very rarely you have stretching. You will see people going around with large goiters. Very rarely you have pain due to large goiters unless they compress. You are right. In a long-standing swelling, hemorrhage can produce acute pain too in thyroiditis, not necessarily decurrence. Any thyroiditis, you can have pain. Okay. Next slide, please. Why did you ask for history of bony pain?
So
Because
bony
whenever
pain,
you say something, you should be able to explain at a postgraduate level. You should be able to justify why you asked and why you did whatever you did. Yeah.
bony pain is a symptom of the suggestive of metastasis, which is usually seen in follicular carcinoma thyroid, where mets are most commonly hematogenous and most commonly to the lung and bones.
Okay. Why did you ask for jaundice?
Sir, sometimes in late metastasis, mets can also be found in the liver, sir. And it's a sign of
How common is it for you to have liver metastasis in thyroid malignancies?
very rare, sir.
No, it is, yeah, maybe in medullary carcinoma or anaplastic carcinoma, they can present with liver metastasis. It's very unusual to have liver metastasis in differentiated thyroid carcinoma. Not that it doesn't occur. Yes, in medullary it can occur. In anaplastic it can occur. And I'm sure for headache and convulsions, once again the same brain metastasis. That's the reason you are. Okay. Sir, Dr. Prabhakar, sir, you want to
sir.
ask any questions so far?
Yes, sir. No history of bony pain. In which bone you can expect secondary metastasis? In thyroid carcinoma.
Sir, follicular carcinomas, they usually metastasize to the flat bones, sir. And mostly in that, most commonly to the skull, sir.
What are the characteristic features of secondary metastatic deposits in the skull?
So
In follicular carcinoma.
So they're usually painful and pulsatile, sir.
Pulsatile. Why it is pulsatile?
So they are highly vascular, sir.
Very good. It's more common in the frontal bone or parietal bone or occipital bone. Secondary deposits.
Frontal, sir.
Yes. Hemoptysis, why you have asked?
Hemoptysis is a sign of pulmonary metastasis, sir.
Pulmonary metastasis. In which condition the pulmonary metastasis will be there?
Again, follicular carcinoma.
Usually papillary carcinoma spreads by which mode?
Lymph nodes, sir.
Let's go to the previous slide. I want to ask some questions in that slide also. Complaints of pain, sir has asked. No complaints suggestive of hyperthyroidism. What is the difference between hyperthyroidism and toxicity? Is there any difference or both are same? Any idea?
Yes, toxic features are usually seen in Graves' disease, as in completely autonomous thyroid, and they usually are accompanied by eye signs.
What do you mean by voice change? What are the two types of voice change? What is the difference between huskiness of voice and hoarseness of voice? In which condition you will get the hoarseness of voice, and in which condition you will get the huskiness of voice?
Hoarseness of voice is usually seen when there's involvement of the recurrent laryngeal nerve, sir. And huskiness
unilateral or bilateral?
Unilateral, sir. Bilateral, usually patient presents with stridor, sir.
Okay. Huskiness of voice?
Huskiness is when it's involvement of the external laryngeal nerve, sir.
External laryngeal nerve. External. What is the which nerve is called Singer's nerve?
External laryngeal nerve, sir, because it helps in
which branch?
sensing.
External laryngeal nerve is having two branches. That is, superior laryngeal nerve is having two branches. One is internal laryngeal nerve and external laryngeal nerve. External laryngeal nerve of the external branch of the superior laryngeal nerve is called
Singer's
nerve. Why it is called Singer's nerve?
Sir, it innervates the cricothyroid, sir, which also functions in tensing the vocal cord, and tensing of the vocal cord helps them to reach higher pitches, sir.
It supplies what muscle?
Cricothyroid, sir.
Cricothyroid. That is the only intrinsic muscle of the larynx that is present outside the larynx. All the intrinsic muscles are present inside the larynx. This is the only muscle which is present outside the larynx. Okay. Yes, go to the next slide.
Can I just interrupt Lavanish for a moment if you don't mind?
Yes, sir.
I'm not fully satisfied with your differentiation between hyperthyroidism and thyroid toxicosis. Let me make it very clear. Hyperthyroidism means the gland is functioning excessively. That's all. There's increased synthesis and secretion of thyroid hormones. Whereas thyroid toxicosis is a circulating state where there is increased level of thyroid hormones in the blood. It may be due to hyperthyroidism or may not be due to hyperthyroidism. I'll give you a couple of examples so that you understand. Yes, you said the Graves' disease. Yes, that is a type of thyroid toxicosis. But even in thyroiditis, that is not hyperthyroidism, but you can get a toxic state. Why do you get a toxic state? In thyroiditis, there's a destruction of the follicular cells. So the preformed hormones are released into the blood, and therefore you have a transient thyrotoxic state. Even a patient who's taking thyroid supplementation, when he takes in excess, he may get toxicity. It doesn't mean he's got hyperthyroidism. So remember, hyperthyroidism means increased synthesis and secretion of thyroid hormones, whereas thyrotoxicosis is a circulatory state where there is increased level of circulating thyroid hormones in the blood. It may be due to increased synthesis or may be due to other causes. Regarding the voice, just wanted to elaborate. Yes, you said about the hoarseness of voice. Pre-operatively, it can be due to your recurrent laryngeal nerve involvement. Post-operatively, it can be due to post-operative damage. The important thing about the external branch of the superior laryngeal nerve is usually what we characteristically say is there's loss of pitch or timbre, which means you can't sing in high pitches. That is why it is very important for teachers, singers, as Sir rightly said. In fact, for opera singers, it is almost a professional hazard. That is why it is not only called singer's nerve, it is also called, it is just some trivia for you to remember. It is called nerve of Amelita Galacurci. Now, this lady was a famous opera singer in 1930s. Apparently, she had a thyroidectomy, and apparently her external branch, when all were thinking about the recurrent laryngeal nerve, the external branch was damaged, and she had to leave her profession. That is why this nerve is otherwise called nerve of Amelita Galacurci. Remember about huskiness of the voice. I would rather use the word loss of pitch or loss of timbre. Huskiness is characteristically used for myxedema. When the patient has got hypothyroidism and myxedema, then they say the patient has got a little bit of a husky voice. Okay? I'm sorry for the interruption, sir.
Yes,
Carry
sir.
on.
Let's go to the next slide.
Yes, sir.
Lavnish. Yes, next slide. Yes, past history. Why you have asked the history of a bronchial asthma in a case of swelling in front of the neck? In what way it is relevant?
Goitre.
Patient is having toxicosis. Will you give propranolol in this patient of bronchial asthma? Lavnish?
Mila?
No, sir. No, sir.
Why?
No, sir.
Why?
Sir,
Your answer is correct.
thyrotoxicosis is a state of sympathetic hyperstimulation, sir, in which there will be increased activation of the beta receptors, producing
Beta 2
tachycardia.
receptors in bronchi will produce dilatation of the bronchi. If we give propranolol, that is antisympathetic, then it will produce spasm of the bronchial muscles. So bronchi. So the patient will have increased difficulty in breathing. So that's why we are not supposed to give propranolol in a patient of bronchial asthma. In what way it is relevant? You have elicited the history of irradiation to the neck.
Sir, radiation exposure to the neck is a risk factor for papillary carcinoma, right, sir?
For what all the purposes they will give irradiation to the neck nowadays or in older times?
Sir, previously, it used to be given for cases of tuberculous adenitis of the neck, tonsillitis, and
Chronic
sometimes
tonsillitis. What do you mean by scrofloderma? Have you ever heard of that terminology? Scrofloderma? Tuberculosis of the skin. Okay. Yes. For chronic tonsillitis, acne vulgaris, scrofloderma, all these things they have given already in the older times irradiation. That will produce what? What type of carcinoma in the thyroid? What type of
papillary
malignancy?
carcinoma, sir.
Papillary carcinoma.
Can I just add something, sir?
Yes, sir. Please, sir.
More importantly, you will say no history of irradiation to the neck, especially in childhood. it is very unusual for you to get exposed in the middle age and get malignancies later on. And the earlier you are exposed, the higher the chance, because only in your first few years of life, the cells are replicating. And that time when you give ionizing radiation, usually that is a very important risk factor for, as sir said, for papillary carcinoma of thyroid. That is why after your Chernobyl, after your Nagasaki, Hiroshima bombing, many of them develop papillary carcinoma of the thyroid. So remember childhood irradiation. And the other indication, the olden days they used to give is for ankylosing spondylitis. Also, people used to give. That is, you have to remember. Then I won't say no history of hypertension, no history of asthma, no history of CAD, no history of CVA. Because you mentioned that only, sir picked up bronchial asthma. I would say no other comorbid features. Remember, just don't unnecessarily elaborate. You should allow the examiner to ask you a question. Now you are giving sir a lead. Then you'll go into beta blockers and he will say what is beta 1, beta 2, and then tangentially you will go off somewhere. Now I want to ask the same question. Patient has got a toxic goiter. Patient heart rate has to be reduced. I want to give a beta blocker. Sir is saying no. What will you do?
I would give a beta 1 selective beta blocker.
Yes, you will give a selective beta 1 blocker. That is the answer. Rather than avoid, because propranolol is a non-selective one, so you'll give a selective beta 1 blocker. So I would rather say no other comorbid features than hypertension, asthma, CAD, CVA. Then I'll ask, why did you not say history of tuberculosis then? So don't unnecessarily commit all this. But so far, we are just trying to fine tune you. Your presentation has been good. I think we can go to the next slide.
Only one question, sir. In this slide, I want to ask, sir.
Yes.
Lavnish, the patient doesn't know about whether the patient is taking thyroxine or anti-thyroid medication. How will you know? By asking the history. The patient is not on any thyroxine supplementation or any anti-thyroid medications. How do you know whether the patient is taking thyroxine or anti-thyroid drugs? Are you able to understand my question, Lavnish?
Yes, sir. Yes, sir.
Yes. How will you know that? If the patient doesn't know, I am taking some thyroid drugs, sir, but all these things, thyroxine or anti-thyroid, I don't know, sir.
In GH, people come from remote villages. They take some
remote.
medication. So how will you identify? Just by history. It's not accurate, but at least it's a pointer in the right direction.
Yes.
Daily.
Thyroxine, it will be taken in the
Daily,
empty
sir.
stomach in the early morning without taking any food. In the empty stomach, it will be taken. Anti-thyroid drugs 2 or 3 times. Okay.
And usually given after food.
Yes,
Not
after
very.
food.
You don't take it in empty stomach. Anti-thyroid drugs. Okay.
Why it should be taken in the empty stomach? Thyroid drugs, thyroxine, Lavnish. Any idea? The absorption will be better. Okay.
Yes,
Right.
sir.
Yes. Go to the next slide. Menstrual history. I want to ask one question. Postgraduate examination question. Patient is having myxedema, that is hypothyroidism. That patient will have menorrhagia or what is the other one? Oligomenorrhea.
Menorrhagia, sir.
Uh,
Menorrhagia, sir.
your answer is correct. Why?
Sir, in mixed edema, that is a hypothyroid state, there will be elevated TSH, sir. TSH is very similar in structure to FSH and LH, sir. And the stimulation of the endometrium and menorrhagia, sir.
Follicular stimulating hormone also will, along with that hormone, it will be also getting increased. That's why the patient will have menorrhagia in the case of myxedema. Very good. Super. Sir, you want to ask any questions, sir, in this slide?
No, I'm quite happy, sir.
Yes, sir. Then go to the next slide.
Because then we'll become historians, because we get stuck in the history.
What is the normal iodine requirement for a human body? Lavnish. Patient is taking iodized salt. I want to ask 2 questions in this sentence. One is what is the normal iodine requirement for human body. Number two, what is the natural food in which iodine is more? Iodine rich diet, natural diet.
Iodine rich diet, seafood, sir.
Seafood, very good. Manjaram fish or any other fish. Then 100 to 125 micrograms per day is essential. Okay?
Yes.
Yes. What
What
do you
is
make?
adverse? What is adverse social habits? What is adverse? What is beneficial social habits? What is adverse social habits? Tell me.
The adverse social habits, smoking,
What is
alcoholism.
adverse for you will be beneficial for me. So I will not use abstract. If you want to say he doesn't consume alcohol, he doesn't smoke, or he smokes, that is the way I will put it. Don't
Yes,
use
sir.
subjective terminology. It may be adverse for you. It may be very beneficial for me. Okay.
Yes, sir.
I hope sir agrees with me, sir.
Yes, sir. Yes, sir.
Hmm.
He
So
has
if
written
you
something about goitrogens, cabbage, mutakos, in Tamil. How it will produce goiter?
Sir, it inhibits thyroid synthesis. I mean, sorry, iodine uptake in the thyroid gland, sir. Hence inhibiting thyroid
Cabbage
hormone
contains
synthesis.
what?
Um, Thiocyanate.
Very good. Thiocyanate prevents the iodine, this hormone production or formation. Okay, iodide trapping. It will inhibit the iodide trapping. Noise of altered sleep pattern. When the patient is having swelling in front of the neck, why you have asked the sleep pattern? In what way it is relevant?
Sir, patients with hyperthyroidism will have reduced sleep, sir, and any large swelling can produce obstructive sleep
What do you mean by
apnea.
positional dyspnea? Any idea? Have you ever heard of the
So,
terminology positional dyspnea?
sir, it's a form of dyspnea that occurs because where a patient reports difficulty in breathlessness in certain positions of the neck, sir. For example, in supine position because of the weight of the swelling over the trachea and
Very good, super. When the patient is having some retrosternal goiter, okay, it may compress upon the trachea or any other things which will produce the difficulty in breathing. Okay, that is called in one particular position, the patient cannot sleep. That will produce a difficulty in breathing. That is called positional dyspnea. When the patient is having multinodular goiter compressing on both sides or right side, if it is very much enlarged and the patient is sleeping on the left side, it will compress upon that. That is in that position, that patient will have dyspnea. That is called
yes, sir.
positional dyspnea. Okay.
what is this? What do you mean when you say excessive intake of goitrogen? So what is normal intake then? Now you have to tell me. This is how if I was the examiner, I'd ask you. Now
Excessive
you
intake.
see,
What do you mean by that? Sir is asking. So little amount of cabbage you can take daily. Yeah? You mean that?
first of all, I'll tell you. Very rarely I mean, I know it is given in the books, but those books are Western books. Very rarely, when we eat cabbage or cauliflower, we will get it because in Caucasian diet, they take salads day in and day out. They take your cabbage, cauliflower, lettuce day in and day out. We don't take it. We take it once a week, cabbage or cauliflower. When a patient asks me, I say, "Kadacha சாப்பிடுப்பான்மா," because that is the first question they'll ask. So it's very unusual for us. So you will say, I'm not saying that you should not mention it, but when you say excessive intake and all that, an examiner will be tempted to ask what is normal intake. So you can say, I mean, if somebody takes all these members of the Brassica family every day, day in and day out, then that may be termed excessive. And very rarely we take raw or thing. We fry it, roast it. What goitrogen is there also will evaporate and go. So it is very unusual for us to have goiter because of goitrogens. It is mainly iodine deficiency, even that because of a government mandating iodine salt, even that is reduced. So this is some practical points. So I won't use excessive intake because then normal intake. So what I would say is probably day in and day out. And you said about history of sleep pattern. I'm quite happy with all your answers regarding that. Thank you. Can we move on?
Yes, go to the next slide, Lavnish. Family history. In what way this family history is relevant in the case of swelling in front of the neck?
Sir, hypothyroidism can be familial. So, females whose mothers or sisters have hypothyroidism, they are at a higher risk of developing the same hypothyroidism. So,
Hyper or hypo? Sorry, I didn't hear you. Hypo. So,
Yes.
so if one sibling has, there's definitely a risk of another sibling having hypothyroidism, is it?
Yes, sir.
Okay.
How it is?
I think I may not agree with you entirely. Sometimes it may run in the families. When most important is there's a condition called, when you say familial, when you say there's a condition called dysharmonogenetic goiter, which is autosomal recessive, then it can run in families. Otherwise, maybe all are taking diet which is deficient in iodine. So that is the more common cause. So if you strictly speaking, hypothyroidism in the family means it is more likely to be dysharmonogenetic goiter, which is a very rare condition. Okay, but
Yes, sir.
most likely it is due to probably not having a proper diet, especially in your rural areas when many members of the family. Okay, because
Yes,
it's unusual for sisters to have goiters unless it is sisters to have hypothyroidism, unless it is dysharmonogenetic goiter. Okay, not that they cannot have. It's unusual. Yeah.
yes.
Lavnish, how many percentage of medullary carcinoma run in families, familial? And how many percentage of medullary carcinoma will be sporadic?
So almost 40 to 50%.
80% familial. And 20% sporadic. Correct, sir? Am I correct, sir? Vittal, sir, or I'm...
Sir, other way around, sir.
Yes,
it is,
80%.
It is 75 to 80% sporadic.
Sporadic,
20 to
20%
25 is familial.
familial.
But actually, if you do more and more genetic analysis, more and more cases you'll soon perhaps identify them to be familial. But strictly speaking, if somebody asks you in the exam, you'll say 75 to 80% is sporadic, around
Sporadic.
20 to 25% is familial, and usually it is due to mutation in the ret proto-oncogene. Okay,
That
I
red
will not go into.
oncogene is present in which chromosome? Lavnish. I will
Sir,
give three options: chromosome number 11, 12, 10.
12, sir.
First answer is the best answer. I
11.
gave you the clue.
12, sir.
Chromosome number 10, medullary carcinoma gene. Okay, it runs
Yes.
in families. So 80% sporadic, 20% familial. Okay. Usually in familial, it will be solitary or multifocality.
Multifocal, sir.
Yes, familial will be multifocal. Sporadic will be.
Remember, any familial anywhere, the cancer will usually be not necessary because the stimulus is generalized. You know, this is general principle. Any any familial disease, whether it's a thyroid or parathyroid, parathyroid means it will be multiglandular involvement. In thyroid means it will be multifocal. These are general concepts you can learn. Okay.
Yes, sir.
Yeah.
What is Pendred syndrome?
So, Pendred syndrome is a form of dysharmonogenesis where the child presents with hypothyroidism, infant presents hypothyroidism because of a mutation in the pendrin gene, so which is responsible for iodine intake into the cell. There's a dysfunction
Patient
in
will
the
also have the congenital deafness.
retinism.
Yes.
I'm very impressed that you are able to say that deficiency of pendrin, which is a protein involved in the transport of iodine across the cell. That's a very good answer. Very good.
Thank you,
Yes, good, super. Yes. Go to the next slide. No history of any malignancies in the family. Okay. Summary. Read it.
A 50-year-old female presented to the OPD with complaints of swelling over her neck, which she noticed 1 month ago, and which has been progressively increasing in size since then. She's a known case of type 2 diabetes mellitus on insulin treatment. She has also undergone an open hysterectomy 20 years ago.
I'm going to interrupt you here. Generally, if you say she's a known case of diabetes on insulin treatment, because normally type 1 is insulin, type 2 is anti-diabetic drugs, but there are patients who will need insulin. So then don't use type 1, type 2. I would say she's a known case of diabetes now taking insulin. It is like, you understand?
Yes, sir.
Because usually type 1 is insulin, type 2 is oral anti-diabetics. In the later stages, when the oral anti-diabetic agents are not effective, then the patient is having insulin. So I would probably say, I'm not saying you're wrong, but because you're good, I want you to excel. Okay. So you probably say known case of diabetic now on insulin. Okay.
Yes, sir.
So
Sir, do you agree with me, sir?
Yes, sir. Yes, sir. Absolutely, sir. After eliciting the history, what's your probable diagnosis, Lavnish?
Sir, based on my history, I would come to a diagnosis that this is a swelling of a thyroid swelling for evaluation, and most likely it's a goiter, sir.
Benign goiter or malignant
Benign,
goiter?
sir. Benign.
What are the points in favor of your diagnosis of a benign goiter? Why can't it be a malignant?
Sir,
Because you are
benign
telling
goiter.
that it is present only for the past 1 month.
Sir, I am saying it's a benign goiter because the patient has noticed it only for the past 1 month, sir. And she doesn't have any symptoms of any compressive symptoms, sir. That could be suggestive of any anaplastic carcinoma. And she doesn't also have any symptoms suggestive of metastasis.
And there is no family history also. There is no family
Radiation
history.
exposure.
And there are no notes. Notes means any supraclavicular fullness, any neck swellings. The patient is not having any history, isn't it? Yes, sir, please.
No. To say 1 month swelling and then say, I would, with the history, to be very frank, I will not be able to say whether it's benign or malignant. Because if it's long duration, then definitely I can say benign. Okay. And then don't say there's no history of compressive symptoms and that is why it is benign. Most of the malignancies, if you see, majority will not have compressive symptoms. Okay. Compressive symptoms occur only in late stages or perhaps in a malignancy like anaplastic. So both the answers you gave need not necessarily say it is not malignant. Okay. So with the history alone, if I get this history without seeing the patient, I will not be able to say it's benign or malignant because short history can be both benign and malignant. Lack of compressive symptoms doesn't mean it is benign. But presence of compressive symptoms, on the contrary, means there's a high chance of malignancy. That is the way I would put it. Okay?
Yes, sir.
You have written it here. It has been progressively increasing in size since then. What is the difference between rapid increase and sudden increase? Is there any difference? Rapid increase in swelling and sudden increase in swelling.
Sudden increases in swelling is a very acute process, sir, within a day or two, sir. Usually seen in any hemorrhage into a cyst. Rapidly increase in size, consistent increase in size that happens over weeks or months, sir.
2 weeks or 3 weeks like that. Here it in days only. Sudden increase means due to hemorrhage. Cystic necrosis due to hemorrhage like that. Yes, good, super. Hysterectomy the patient has undergone 20 years ago. In what way it is relevant to the swelling in front of the neck? Is there any relevance?
Sir, in some patients, like those in familial diseases, like in Cowden syndrome, where the patient has an increased risk of endometrial carcinoma, that case it can be relevant, sir.
Okay.
Okay,
Don't
go to
you-
the general.
Yeah,
Yes, sir,
don't you
please.
think it is a bit unusual? The ladies, I mean, it's just a comment, nothing to do with your presentation. The lady is 50 years and she's had a hysterectomy 20 years ago. So at the age of 30, she had a
30 years.
hysterectomy. A little bit surprised, you know. I'm not saying it is untrue. How many children has she got?
2 children, sir.
How many children?
2, sir.
Two children. What are they? Okay. Anyway, just a comment. Oh, carry on.
Yes.
Okay, go to the general examination.
General examination. The patient was examined with a female companion in a velvet room. The patient is conscious.
I will interrupt you. Sorry. Don't say male companion, female companion. Just use the word chaperone if you want to say. You
Yes,
need
sir.
not say. If at all you want to say, use chaperone. Okay.
Yes, sir.
Uh,
The patient was conscious, oriented, afebrile, and well hydrated. She is well nourished. She has a BMI of 31. Her blood pressure is 130 over 80 millimeters of mercury measured in the right arm in sitting posture. And her pulse is 84 beats per minute, which is regular in rhythm and normal volume. Her body temperature is 98.3 degree Fahrenheit. She has clinical pallor, but she does not have any ectris, cyanosis, clubbing, fetal edema, or peripheral lymphadenopathy.
Why
Her
it is
Why do you
pulse
want to
is? Yes, sir.
come back? No. When you
Go to
say
the
afebrile, why again you want to say temperature is 98.3? We are not so dumb, no? Either say afebrile and leave or say the temperature.
Yes.
You
In
wanted
what
to
way
say.
pulse is important in a case of swelling in front of the neck? Lavnish.
Sir, in case of hyperthyroidism, the patient can have arrhythmias, most likely an atrial fibrillation, where the patient can have tachycardia with an irregular pulse.
What do you mean by mild tachycardia, moderate tachycardia, and severe tachycardia?
So mild tachycardia is when the heart rate is from 90 to 100, moderate is 100 to 110, and severe is more than 110. Sir.
What do you mean by sleeping pulse rate? Have you ever heard of that terminology? Sleeping pulse rate?
Sleeping pulse rate is the pulse rate that denotes the resting pulse rate of the patient in their basal sympathetic tone, sir. It's usually measured in the early morning just before the patient wakes up, sir.
Why do you want to measure sleeping pulse rate?
Sir, during the day, the patient can have an increased sympathetic drive, sir. But when during the rest, the patients are usually at their basal sympathetic tone, which can be unusually increased in case of hyperthyroidism, sir.
I'm sorry, I beg to differ. First of sleeping pulse rate is used to differentiate toxic person with toxic symptoms from a patient with anxiety neurosis. Classically, that is the reason. Nowadays, we don't measure sleeping pulse rate because those days we did not have all the intricate laboratory thyroid function test everywhere. So this is a clinical diagnosis. You want to know whether patient is clinically toxic or whether patient has anxiety neurosis. Those days they used to measure sleeping pulse rate. I think in the present scenario, it's very rarely required, but it is required for you to know in the exam. So even in a patient who is toxic, even when he is sleeping, his pulse rate will be relatively high. Whereas a patient with anxiety neurosis, he will be anxious when he is conscious and when he is awake. When he is sleeping, the pulse rate may be low. That was the concept which was used, very sparingly used nowadays. Okay.
Okay. And you have mentioned about no pedal edema. What do you mean by pre-tibial myxedema?
So pre-tibial myxedema
It will be present in the myxedema or in the hyperthyroidism, Graves' disease.
Graves' disease, sir.
Graves' disease. Pre-tibial myxedema. What is the concept behind that? What is pre-tibial myxedema?
The pre-tibial myxedema is there's a deposition of glycosaminoglycans in the subcutaneous
Deposition
layer.
of mucopolysaccharide in the subcutaneous layers in the legs, isn't it? Yes. It will be present in the Graves' disease, pre-tibial myxedema. No
Where is
peripheral.
it present? Where do you find pre-tibial myxedema classically?
In Graves' disease, sir.
No, I'm sorry. Which anatomical portion?
Anterolateral aspect of the leg, sir.
Anterior aspect. How will you identify whether it's morphologically? How will you identify when you see the patient? Is it edema per se?
No, sir. It's
Then
not. It's a non-pitting hardening, sir. That's
hardening. So just because it is hard, so what is the morphologically? How do you describe that? Okay, lack of time. Purple or pinkish plaque, which is found in anterior aspect, little bit difficult to identify in the colored races, whereas in the white races you can identify them more easily because of the pinkish or purplish pink plaque on the anterior aspect, as both of you rightly said, glycosaminoglycan, which is a part of mucopolysaccharides, present in Graves' disease. When you have pretrabeal myxedema, you will definitely have eye signs. Okay, remember this is a dictum. So when you have Graves' disease, what are the 4 components of Graves' disease?
sir. Graves' disease. One patient will have hyperthyroidism. He'll have
Hyper.
thyroidism. Thyrotoxic state be there. Then the patient will have ophthalmoplegia and
Okay, you just now mentioned we have lack of time. Yes, diffuse toxic goiter. Okay. 2, yes, not necessarily ophthalmoplegia, eye signs. Nowadays they use the acronym TED, thyroid eye disease. 3, just now we mentioned pre-tibial myxedema. 4, acropathy, which is nothing but clubbing and enlargement of the subcutaneous tissue. All 4 components need not be there necessarily. It is usually the goiter and eye signs. 3 and 4, pre-tibial myxedema and your acropathy is little bit rare. But these 4 are the full components of Graves' disease. Okay.
Usually pre-tibial myxedema will be present unilaterally or bilaterally, common.
bilateral, sir.
Good, very good. Okay. What is
Carry on,
primary
please.
thyrotoxicosis and secondary thyrotoxicosis?
Sir, primary thyrotoxicosis is usually seen in younger patients where there's no clinical goiter, but the patient will have features of thyrotoxicosis or hyperthyroidism, sir. And patient usually presents with neurological symptoms. Secondary thyrotoxicosis usually occurs in late stages after a long-standing goiter, and it usually presents with cardiovascular signs like heart failure or palpitations and fatigues.
Why it's called primary? Why this one is called secondary thyrotoxicosis? Any idea?
Sir, primary thyrotoxicosis, the primary pathology is, for example, Graves' disease, sir, where there is the initial pathology is a hyperfunctioning of the thyroid gland. Whereas in
What I
secondary,
am asking is why it's called primary. Primary hydrocele means the etiology is not known. Like that, for this the goiter, primary goiter, the etiology was not known at that time. Now only it has been identified, isn't it? That's why it's called primary thyrotoxic. Secondary thyrotoxicosis, what is the reason? What is the concept behind that?
the secondary
Due to the
thyrotoxics in long-standing goiter or a multinodular goiter, there'll be
autonomous
an
nodule.
autonomous functioning of some of the nodules.
Okay, go to the next slide.
Sir, can I just interrupt here?
Please,
just
sir,
to
please.
clarify things. You said in first primary thyrotoxicosis, you'll have toxicosis, no goiter. That is wrong. I will just differentiate between two. Primary thyrotoxicosis means the symptoms and the goiter come more or less simultaneously or peri passu. That is more or less the goiter simultaneously means not that they occur in the same day. In a short period of time, goiter and toxicity occur. Secondary thyrotoxicosis means in a long-standing goiter, usually a larger goiter, long-standing goiter, when a toxicity supervenes, it is called secondary thyrotoxicosis, number 1. Number 2, primary thyrotoxic, as you said, occurs in a younger females. Secondary thyrotoxicosis in a elderly age group. Primary thyrotoxicosis is usually autoimmune etiology. Secondary, not autoimmune. Primary thyrotoxicosis is usually it can occur in any area, whereas secondary is usually in endemic areas only. You have these big goiters and they can occur. In primary thyrotoxicosis, you have eye signs. In secondary, you will not have eye signs. In primary, you will have, as Sir said, predominant neurological symptoms, the tremor, anxiety. In secondary, it is more cardiological symptoms. Okay. Then in primary, because it is autoimmune, you can start them on anti-thyroid drugs and there's a chance of remission. In secondary, you can give anti-thyroid drugs, but the chance of remission is less, and at some stage you will require definitive management. You should have clear concepts. Okay, I hope
Yes,
I'm clear. Thank you.
Completion sake, only one question. Why particularly CNS symptoms in primary thyrotoxicosis and why CVS symptoms in secondary thyrotoxicosis? Lavnish.
Sir,
Sir has told.
in primary thyrotoxic, usually younger people, sir, and there's a sympathetic overactivity. So you usually have more neurological symptoms. And secondary thyrotoxic usually affects older people who may already have some degree of heart failure, and hence the cardiovascular symptoms are they surface easier.
Not necessarily heart failure. I'll just refine your answer. There's more a hyperdynamic circulatory state. Okay.
Yes.
And because they're elderly, there's a more chance of cardiovascular problem, but it's more hyperdynamic circulatory state. Okay.
Yes, sir.
Good. Go to the next slide.
Eyes appear normal, normal lid position, and normal eye movements. No fine tremors noted over the hands or tongue. No dilated veins over the neck. There are no features suggestive of Horner syndrome.
Why
What
did you
type
ask for
of
features of? Sorry, sir.
Yes,
You,
yes,
you
please,
first,
sir.
sir. No, sir, you first, sir.
What type of tremors you can expect in a case of primary thyrotoxicosis?
Testing fine tremors, sir.
And how will you clinically test for that, whether the patient is having tremors or not?
Sir, am I audible, sir?
Yes.
You're audible. Don't worry. You're waiting for your correct answer.
Sir, the tremors can be in the hands can be demonstrated by asking the patient to extend his hands in front of him, and you can for 30 seconds, sir, and you can check for fine tremors. You can also keep a piece of paper on top of the patient's hand and note for any fine movements in the paper, sir.
Once again, I want to refine.
Yes,
You
yes.
don't just outstretch alone. You have to keep the fingers apart. Only then, yes. If you just keep it like this, still you can miss. As you rightly pointed, you just have a fine tremors. What are the types of tremors you know? What is unfine tremors then? Or what is the bad tremors?
What is coarse tremors? What is the difference between tremors and fasciculations? These are all the questions that can be asked in the exam. What
Where
are
do
the
you
types
get?
of tremors?
Yeah.
Fine tremors can be seen in Parkinson's or
No. We won't waste time. Fine tremors are seen in toxicosis and anxiety. Coarse tremors are seen in Parkinsonism. Then the Parkinsonism tremor is more likely pill rolling tremor. There's another type of tremor seen in cerebellar disease that is called intention tremor. Tremor will not be there, but when you want to do some activity, the tremor will be exaggerated. Whereas in Parkinsonism, you will have tremor even at rest, it will be pill rolling movement. So those are coarse. Coarse means it is more obvious. Fine tremors means it is more subtle. Okay.
yes.
Thank you.
Yes. In which condition you will have dilated veins over the neck in a case of swelling in front of the neck?
Sir, any retrosternal goiter, sir, that compressing the great veins of the neck can produce dilated veins over the neck, sir.
What are the components of Horner syndrome?
Horner syndrome, one you can have enophthalmos, ptosis, anhidrosis, and meiosis.
In which condition you will have Horner syndrome? in a thyroid lesion?
Anaplastic carcinoma, sir.
Anaplastic carcinoma. What is the concept behind that?
Sir, when there's infiltration or compression of the sympathetic ganglia, sir, T1 ganglia.
Cervical sympathetic chain, when it is getting compressed by thyroid lesions, the patient will have Arnold's syndrome, isn't it?
Yes, sir.
Okay, eyes appear normal. What is the difference between exophthalmos and proptosis? Is there any difference or both are same?
Sir, exophthalmos is the component of exophthalmos is only lid retraction, sir. Both the upper and lower eyelids, sir. Whereas proptosis is a protrusion of the eyeball, sir, because of deposition in the orbit, sir.
Clinically, how will you differentiate exophthalmos and proptosis? Which one will be unilateral? Which one will be bilateral? Exophthalmos usually it will be
Bilateral. Sir.
bilateral. Proptosis it will be unilateral. Isn't it? Normal eye movements. Sir, you want any questions, sir? You want to ask any questions from this?
No, I'm fine. The only thing he said, proptosis is due to, what did he say? I didn't want to interrupt.
Sir,
he said due to
deposition of glycosaminoglycans in the orbit.
That is only the cause of exophthalmos. That's why I didn't want to say. So, proptosis is more a generalized term.
Yes.
Okay. It's more exophthalmos itself is a type of proptosis. Proptosis can be even due to retroorbital tumors. Yes. You understand? Whereas exophthalmos is what? You said something.
Deposition of
that is antigen antibody reaction. Because of that, there's inflammatory infiltrate. Because of the inflammatory infiltrate, there is fibroblast proliferation. Because of fibroblast proliferation, there's glycosaminoglycans. But what does the glycosaminoglycans do? They are hydrophilic in nature, and therefore there's an increase in the interstitial water content in the retrobulbar area. In addition, the chronic inflammatory infiltrate both push the eyeball forward.
Yes.
How will you measure exophthalmos? Using what is called exophthalmometer. That is an objective way. Okay, that's a clinical way. There's an objective way. Okay.
Yes, sir.
What is Nafziger sign?
Sorry, sir?
Nafziger sign. Abdul sign to tell next. At the angle of the eyebrows, when you see the cornea will be protruded. You can see that is called what sign? Nafziger sign. Am I correct, sir? Vittal, sir?
Sir, I don't go into details with all the named signs. What I would do is examine the movements, learn the signs for the exam. The common thing is lack of accommodation, convergence accommodation, which is Mobius sign.
Mobius
then,
sign.
Yes. Then stare look, which is the Stellwag sign. These are all more important in the examination. I know, but in the exam, we are supposed to know these eponymous names. That is Stellwag sign. Then you have
Von Graff sign, Joffroy sign, Dahlen-Treitz sign.
Abscess of wrinkles in the forehead. So yes. All these exams, but I'm not sure about your sign, sir. Pardon me for my ignorance, sir.
Okay, sir. So you have to know all these things, lamination. Some examiners may ask, okay. But okay, right.
But you should definitely test for lid lag. Number one. Number two, you should definitely see for accommodation. Number three, you will also see features whether there is the starry look, absence of wrinkling. Number four, you will also measure for eye movements whether there is any extraocular muscle involvement. Number five, you will also see for vision, because in the late stages, your optic nerve can also be involved. The thyroid eye disease is a separate lecture and a separate entity by itself. We will not go into it because I don't think we are dealing with a toxic thing now. Yeah.
Which eye sign will be first appear? Lid lag.
That-
What is
that
the
is-
last I say? Convergence. Loss of convergence. Okay, go to the next slide. Yes.
local examination, a diffusely enlarged thyroid could be noted, in which a single oval, well-defined 2x2 swelling is noted in the right anterior aspect of the neck in the region of thyroid. The swelling moves with deglutition. The surface of the swelling is smooth, and the skin over the swelling appears normal, and the swelling does not move with protrusion of tongue. Another swelling of similar nature of size 2x2 is noted in the left anterior aspect of the neck in the region of thyroid. The inferior border of the thyroid could be visualized. No star sinus or dilated veins to be noted. No visible pulsation. The trachea appears to be in the midline. On palpation, the swelling is not warm nor tender. Inspectory findings are confirmed. About the 2x2 swelling in the right lobe of thyroid, the extent is 6 centimeter from the hyoid bone, 2 centimeter from the sternal notch. It lies just medial to the midline. Laterally, it's 1 centimeter medial to the anterior border of the right sternocleidomastoid, and it's firm in consistency, and the surface is smooth. Above the left 2x2 centimeter swelling, that's also 6 centimeter from the hyoid bone. Inferiorly, it's 3 centimeter from the sternal notch. Medially is just lateral to the midline, and laterally 1 centimeter medial to the anterior border of sternocleidomastoid. Left sternocleidomastoid. It's also firm in consistency and surface is smooth. The rest of the thyroid gland has a nodular surface and is firm in consistency. The inferior border of the thyroid could be felt. The carotid pulse is felt bilaterally, and the trachea is in the midline. There's no palpable thrill. Percussion, there's no retrosternal dullness. And on examination of the lymph nodes, no palpable nodes could be noted over the neck.
I am a bit confused after your clinical examination. I'm sorry. Come back. Come
Go
back.
to the first slide of
Now,
inspection.
yeah, no. Now, all this is okay. You say diffusely enlarged. Okay, that can be in inspection. It can be anything. I will not ask you the basic questions why the thyroid move. I'm sure you know the reason. You'll be 100% confident. Am I right? I don't need to ask you, right?
Yes.
Say confidently. Don't ask
Yes,
me.
sir.
Sir.
Yes, sir.
Then let's go down. Now next. See, you are saying that it's a diffusely smooth swelling. Then you are saying I'm able to see 2 or 3 smooth swelling. Then in between you are seeing nodules. This is where either it is diffuse or nodular. Okay, you can't say one nodule is smooth and firm in consistency, surface is smooth. They all don't correlate. Either what you should say, it is I'm able to see I'm able to feel, sorry, a nodular swelling and multiple nodules. One nodule is in the right lobe, another nodule. That is the way I would describe, because according to you, each nodule is diffuse swelling. That's the way you're describing to me. Sir, correct me if I'm wrong.
Yes, sir. Yes, sir. Yes, sir.
Because come to the next slide. Then rest of the thyroid has a nodular surface, you say. Then what is this? These are not nodule, is it?
These are the prominent nodules that I could note, sir.
So what I will say is it's either a diffuse swelling or I'm able to feel a goiter which has got multiple nodules. And then you say one nodule I'm able to appreciate in the right lobe, perhaps characterize, one nodule in the left lobe. That's the way you characterize. If I don't see the patient, if I close my eyes and hear you, I can tell you I'll feel very confused, because it's very simple. Either it's a diffuse swelling or a nodular swelling. You can't say I am able to find a smooth nodule. Okay.
Yes.
Sir, because that
Yes,
is
sir.
like putting something from here, putting something from there, and making a hash of things. It's either diffuse or nodular, according to me. It is
Yes.
classically you're able to see nodules. You are able to feel nodules everywhere. So I think you should present it as goiter, which has got multiple nodules. One nodule in the right lobe, and describe the nodule, and one nodule in the left lobe. And whenever you describe nodule, whenever you say surface is smooth, you indicate it is diffuse. I would rather say the surface is nodular. Okay.
Yes.
And the other thing I say, thrill itself is a palpatory finding. I will say no thrill. What is palpable thrill? Then I'll ask what is impalpable thrill. Okay, thrill itself is a palpatory finding. Brewery is a auscultatory finding. Okay. Sir, I feel free to correct me if I'm wrong, sir.
Yes, sir, you're absolutely correct, sir. Yeah, right. Sir, can I ask you some questions, sir?
Please, sir.
Yes, go to the previous slide, inspection. Some basic questions I want to ask. These questions will be asked in your inspection.
Oh, sorry, sir.
Trachea appears to be in the midline. How do you know? By inspecting?
Sir, we can inspection. You can look for the trail sign, sir, where the medial, the clavicle, the sternal head of the sternal mastoid will be more prominent towards the side which the trachea is deviated, sir.
Okay, inferior border of the thyroid could be visualized. What is the importance of that?
Sir, usually the inferior border of thyroid cannot be visualized in case of retrosternal goiter, sir.
Usually thyroid swelling moves with the deglutition. Though it is a thyroid swelling, some of the thyroid swellings will not move with the deglutition. Why?
Sir, if it's a thyroid swell, a malignant thyroid swelling that's infiltrating into the surrounding strap muscles.
Carcinoma of the thyroid infiltrating to the nearby structures. Number one. Number two, huge goiter. Number three, retrosternal goiter. Okay, these are all the thyroid swellings. Though they are thyroid swellings, it will not move with the deglutition. What are the 5 swellings that will move with the deglutition? Or what are the swellings that will move with the deglutition?
The one thyroid
Yes.
swelling, any lymph nodes that are attached to the trachea or the larynx, sir.
Okay.
A thyroglossal cyst or
Okay.
a subhyoid bursitis can
Then?
move, and any pharyngeal diverticulum can
Laryngocele.
laryngocele.
Okay.
Don't get caught with pharyngeal diverticulum. What is then they'll go into Zenker's diverticulum and all that. Okay. Why should a subhyoid bursa move?
Sir, it's attached to the hyoid bone, sir, which moves with deglutition.
Okay, we won't ask that because we carry on. You said this
Okay.
trachea appears to be in the midline, and sir said, and you said, how will you identify if there's tracheal shift? You said prominent of the ipsilateral sternomastoid.
Yes, sir.
Why should the ipsilateral sternomastoid be prominent? Do you think the trachea is pushing the sternomastoid and therefore it becomes prominent?
No, sir.
Have you ever thought about it? Okay, if the trachea is shifted to the right, that means the right sternomastoid becomes prominent. Am I right?
Yes,
That
sir.
is what is the concept behind it? Do you think the trachea, because it is pushed to the right, it is pushing the sternomastoid in front? Okay, lack of time. When it moves to the right, ipsilateral, the cervical fascia is relaxed. And remember, this muscle is enclosed. So when there's relaxation, see, just imagine when somebody holds you, you don't see. When there's a relaxation, the muscle becomes prominent. That is the concept of the trail side. Okay.
Yes, sir.
Thank you.
Yes, go to the next slide.
So I think you can make those changes. We will not go into the details. And I don't think you can say 6 centimeter from the hyoid bone, 2 centimeter. I don't think you need to go into so much detail to describe these nodules when you have said these are all smooth surfaces. Okay. So try to rectify that. Say it's a nodule, multiple nodules I'm able to see. Whenever you say about the nodule, I would say firm in consistency, nodular in surface. Because when they say surface is smooth, you are indicating it is more likely to be a diffuse goiter. Okay. Bossulated surface would be the ideal terminology. Everything should add up,
Yes.
Carry on.
You are telling that it is a firm inconsistency. Go to the previous slide. Firm inconsistency. What do you mean by thyroid paradox? I'm having 2 questions to you. One is, what is thyroid paradox? Answer first. Any idea? though it is a cystic swelling, it will appear as a, it will be felt as a firm swelling. Why?
Because
Because of the
tense
investing
fascia.
layer of the deep cervical fascia. Okay.
Yes.
And if it is a firm swelling, it can be, or it's a malignant swelling, it can be, it can appear as a cystic swelling. Why? Because of the cystic degeneration. Okay. Thyroid paradox, that is called. Okay. Right. Then, what is the difference between a nodular surface and basilated surface? Is there any difference or both are same?
Not aware, sir.
Nodular means below 2 centimeter. Basilated means more than 2 centimeter.
Yes.
The swellings. Okay. Yes. Go to the next slide.
What
Rest
is
of the
the
Yes, sir.
significance about the carotid felt bilaterally?
Mm.
Because
Where-
that is a normal for everybody. What is the significance in this case?
Sir, a large multinodular goiter can push the carotids posteriorly, sir, hence displacing the carotid pulse.
Okay, so what? Okay, then what is Berry sign?
The very sign is when the carotid is not felt on the ipsilateral side because of encasement of the carotids by a malignant lesion of the thyroid.
Good.
Absence of carotid pulse or presence of carotid pulse? Which one is called Berry sign positive?
Absence.
Where will you palpate the carotid pulse?
Sir, in the lower third of the between the sternocleidomastoid and the trachea, in the lower third against the C6 transverse process, sir.
Against one tubercle in the transverse process of the cervical, C6 cervical vertebra. What is the tubercle called? Chesagny tubercle. Okay. In the upper border of the thyroid cartilage, in the groove between the sternocleidomastoid and the trachea. Okay. In that groove, groove, you can see that tubercle against that bone, which when you are palpating the carotid pulse, you are palpating common carotid artery or internal carotid artery or external carotid artery?
Common carotid, sir.
Common carotid artery. Can you feel the carotid pulse at the same time on both sides?
No, sir, we shouldn't.
Why?
Sir, while if we do so, we may induce syncopal attacks, sir, because of stimulation
Okay.
of the baroreceptors.
When you are palpating, when you are looking for the thrill, where will you look? In the inferior pole or in the superior pole of the thyroid gland?
Superior pole, sir.
Why? Your answer is correct. Three
Sir,
reasons are there for that. What are they?
so you palpate in the superior pole because that's where the superior thyroid artery is present most superficially, sir.
Number one, superficial. When compared to the inferior thyroid artery, superior thyroid artery is superficial in the superior pole. Number one. Number two, it is a direct branch, first branch of the external carotid artery. So, thrush of blood long is more in the superior pole. Number three, this superior thyroid artery divides into anterior and posterior branch in the parenchyma of the superior pole.
Okay.
It enters into that and it divides. But inferior thyroid artery divides into multiple branches even before entering into the thyroid gland. For these three reasons, we have to look for the thrill in the superior pole of the thyroid gland. Go to the next slide.
Same way, even the auscultation is in the superior pole.
Yes. Yes. Retrosternal dullness, why you have looked for?
Retrosternal dullness, you look for any retrosternal extension of goiter, sir.
Retrosternal extension of goiter.
Yes, sir.
What are the two types of retrosternal goiter?
So one, it could be a goiter that's arising from the neck, a cervical goiter that's become large enough to extend into the
that is called secondary type. Primary type of retrosternal goiter is one that it will arise from the ectopic thyroid. Which one is called plunging goiter? Primary type or secondary type?
Secondary types.
Secondary type. Why it's called plunging? Because whenever the patient coughs, at that time only this the goiter will come to the neck. Otherwise, it will not come. That's called plunging goiter. But the goiter arising from the ectopic thyroid tissue, it will not come to the neck. Okay.
Yes.
Retrosternal goiter. No palpable lymph nodes. Where will you look for?
Sir,
Which level of lymph nodes you will look for in a case of carcinoma or malignancy of the thyroid?
sir,
Levels.
the first lymph nodes that drain into the drain the thyroid are
Level 6,
and 7, sir.
level 3, and level 4. Okay. It will not, it will never usually go to the level 1 and 2. Okay. 6 and 3, very common. Okay.
Just I want to add,
Yes, sir.
it's very unusual for you to palpate your level 6 and 7.
Yes, sir.
You can't normally palpate your central compartment lymph nodes. What you normally palpate, sir, I just want to make a correction. I
Yes,
agree
sir.
with you. Level 1 is unusual. Level 3 and level 4, along with 6 is common, but level 2 is also involved, sir.
Okay,
So
sir.
level 2, level 3, level 4, apart from that central compartment, and occasionally level 5. But what is normally palpable is your 2, 3, and 4, and occasionally 5. Central compartment lymph nodes are very rarely palpable, although if at all involved, they are the first region to be your level 6. That is your pretracheal, paratracheal, and the prelaryngeal lymph nodes are the first lymph nodes to be involved. And the second group is your level 2, 3, 4, and 5. Maybe rarely you may have skip metastasis, that is, without involving the central compartment, it can involve the lateral compartment in maybe around 20 to 30% of patients, especially with superior fold tumors. Okay, so remember, first is the central compartment, next is the lateral compartment. That is why in thyroid surgery nowadays we do what is called compartmental resection. Lateral compartment, central compartment, mediastinal compartment. Okay, so mediastinal compartment is below the brachiocephalic vein. Central compartment means level 6 and level 7. Lateral compartment means 2, 3, 4, and 5. One is I get a message from Connect that we have to finish in 10 minutes. Anyway, lateral compartment, level 1 lymph nodes are very rarely involved. Okay, let's go on.
Okay, yes. What
I
is the
think due
other
to
name
lack
of the, what is the other name of the prelaryngeal lymph node?
Delphian.
Huh?
Delphian node, sir.
Delphian node. Okay, right. Yes.
I think other systems will omit. I think we'll have to go to examination proper.
Yes, summary.
Yeah.
Yes, read
Summary.
it.
50-year-old female presented to the OPD with complaints of swelling over her neck, which she noticed 1 month ago and has progressively increased in size since then. She is a known case of type 2 diabetes mellitus on insulin treatment. She has no history suggestive of hypo or hypothyroidism. On examination, a nodular goiter is noted, of which 2 swellings are most prominent. A single oval, well-defined 2x2 swelling is noted in the right anterior aspect of neck, the region of thyroid, and another swelling of size 1+1 centimeter is noted in the left anterior aspect of the neck in the region of thyroid.
Okay. What's the diagnosis?
Provisional diagnosis. This is a case of multinodular goiter with no features of hypo or hypothyroidism and no features suggestive of malignancy.
I will just correct it here. I will not say no feature of hyper. I will say case of multinodular goiter with a patient being euthyroid. And don't unnecessarily commit no feature suggestive of malignancy. I would just in the case of multinodular goiter with a patient in euthyroid status. What do you think, sir?
Yes, sir. Yes, sir.
Clinically euthyroid. That's all.
What you are
Okay.
going to do for this patient? You are going to give any medicines or you are going to do any surgery for this patient? If a surgery, what are the indications for surgery in this particular patient for a case of multinodular goiter?
First, what will you do? What are the basic investigations? We don't have much time. We are going to run through now.
Yes.
First, I would like to confirm my diagnosis of the euthyroid status. I would like to do a thyroid function test, look for the TSH levels. Then I would like to do an ultrasound of the neck, and then based on the ultrasound report on the thyroid status, I would go for a USG guided FNAC of the thyroid, sir. And based on these findings, I also go for a video laryngoscope of a video.
That is
video
not
of-
diagnostic. You only told me 2 tests. That is not diagnostic.
That's
Your
right.
laryngoscopy. That
That's
is
an inspective
so.
finding.
Yeah. So you will have an anatomical diagnosis, physiological diagnosis, one test, and a pathological. Your first thing should be your thyroid function test to exclude hypo or hyperthyroidism. Your next one would be an ultrasound scan. An ultrasound scan is usually the way you do it is your thyroid staging, where you want to see whether the risk of malignancy in a particular nodule. And then if the nodule is suspicious or if a nodule is dominant, then you will want to do an FNAC. And how is the FNAC interpreted? It is used usually via Bethesda classification. What was your FNAC finding? What is the ultrasound finding?
The USG for this patient was a thyroid 3 lesion on both the lobes of the thyroid, and proceeded with an FNAC. RHS.
Sorry, carry on. Yeah.
FNAC, we found that the right swelling had was a Bethesda score of 2, and the left one was a Bethesda score of 1, stage 1.
So what did you do for him? Or her, sorry.
Sir, this patient, I would like to go for a total thyroidectomy.
Why do you want to offer surgical intervention to the patient?
So the patient, actually, when we found out the main complaint for her was cosmesis, sir.
Cosmesis. So what are the indications for surgery in a multinodular goiter?
Indication for surgery are 1, cosmesis, 2,
okay,
any compressive symptoms, 3,
pressure
any autonomous
symptoms.
nodule, 4,
That is
any
toxic symptoms. Don't
toxic.
use autonomous. 1 is cosmesis, 2 is compressive, 3 is toxic, then
4 is any nodule has become malignant, sir.
So chance of 5, retrosternal extension.
Okay, sir.
Okay, these are the indications for surgery in a multinodular goiter. And
Which
what
type
did you
of
do for
carcinoma is common in multinodular goiter?
Follicular carcinoma, sir.
Okay, right. Yes, sir.
what did you do for this patient?
This patient, we proceed with a total thyroidectomy, sir.
Okay.
Which type of toxicity is common in multinodular goiter, long-standing multinodular goiter?
Secondary.
Primary or secondary?
Secondary, sir.
Secondary thyrotoxic. What is the other name of the secondary thyrotoxicosis occurring in MNG? Plummer's disease.
Plummer's disease.
Okay, right.
Okay, you said you did total thyroidectomy. So why did you do a total thyroidectomy?
Why can't the subtotal thyroidectomy? Sir is asking. Why do you prefer?
Sir,
Why do you particularly?
in subtotal thyroidectomy, we leave a part of the gland, sir, the superior poles, but the risk of that particular thyroid tissue can also present later as a malignancy or can become an autonomous.
Nowadays, we don't do subtotal. First of all, not necessarily superior pole. You leave around 5 gram or whatever they say. Nowadays, those are all abolished. You do total or near total thyroidectomy. Okay.
Yes, sir.
Now tell me, how will you follow? How will you follow up a patient with total thyroidectomy? What will you do after a patient having total thyroidectomy? What will you do?
So first, I would collect the histopathology report of the patient, sir.
What was your histopathology report?
The histopathology for this patient was a colloid goiter, sir, with hemorrhage.
So what will you do for her now?
So for this patient, I would go for a thyroxine replacement is sufficient for this patient, sir.
What is the normal dose you give for the patient?
We can start with 100 micrograms per day, sir.
On what basis you start 100? Empirically or just because you like 100? Okay, lack of time. Generally, anywhere between 1.4 to 1.6 microgram per kg per body weight is the normal replacement dose. Okay, so you can give it, but over the period of time, because we know average body weight, people start on 100 and later on titrate the dose. What are the complications of thyroidectomy?
Complications of thyroidectomy, first, immediate complications. First, the patient can develop a hematoma, sir. A hematoma on post-operative
Operative complication and post-operative complication. What are the perioperative complications?
Perioperative complications, there could be a injury to the nerves.
Where will you look for the recurrent laryngeal nerve during thyroidectomy?
So it will be just deep to the tubercle or Zucker candle, sir.
Non-recurrent recurrent laryngeal nerve is common on the right side or on the left side?
Non-recurrent
Recurrent
left side,
laryngeal
sir.
nerve. Huh? Right side it's very common. Non-recurrent recurrent laryngeal nerve. Okay. Okay, right.
Why is it? First of all, it's a rare condition present in 0.5 to 1%. But why should it occur on the right side? Why should it not occur on the left side?
Subclavian artery, right side absence.
So what happens on the right side? Normally the nerve winds around the right subclavian, whereas on the left side it winds around the arch of aorta. Whenever there is an aberrant origin of the right subclavian, then the nerve cannot wind around the subclavian. So it is given directly from the vagus. That is why your non-recurrent nerve is nowadays they call it as a direct nerve as well. Whenever you have a non-recurrent nerve, you have to suspect abnormal origin of the left right subclavian from the arch of distal to the left subclavian. In that case, it can compress the esophagus and cause a condition called dysphagia lusoria. These are all rare, but the examiner will ask you, what are the other complications?
Sir, we may lead to an invertent parathyroidectomy, sir. We may inadvertently remove it with the thyroid specimen. If we do so, then we have to auto transplant the parathyroid specimen into the ipsilateral sternocleidomastoid or brachyradialis.
Both the superior and the inferior parathyroid part of parathyroid glands are supplied mainly by superior thyroid artery or inferior thyroid artery.
Inferior thyroid artery.
Okay.
So you tell me the complication. You told me about hematoma. What else is there? How will you prevent hematoma?
So we can keep a drain.
No drain prevents a hematoma. Okay. One, hemostasis should be meticulous. Two, where before closure, you always do a Valsalva maneuver so that even if some of the vessels which you have missed out will open up and bleed. Why are you so concerned? Because it is a closed space. If you don't identify a hematoma on an emergency basis, that can cause tracheal compression or it can cause laryngeal edema, tracheal compression, and death. So, hematoma following post thyroidectomy, although it is not common, it is a lethal complication and can be avoided. Okay. Tell me the other complication. You talked about parathyroids. What happens? What are the effects of injury or ischemia due to the parathyroid? How does it present?
The patient
will be the first sign of parathyroid deficiency post-operatively. The patient will have
leading to perioral numbness, sir.
Yes. What are the other signs related to that? Sorry,
one is Trussier sign, which is demonstrated by inflating the. We put a BP cuff around the arm and we inflate it above 20 millimeters of mercury above the systolic blood pressure, and you note for the carpopedial spasm that occurs in the fingers, sir. That's the Trussier sign. You also have the Chvostek sign, where tapping at the just below the tragus, you can stimulate the facial nerve, leading to spasms.
See, the patient will not complain with the signs. The patient will complain of perioral numbness and numbness or pins and needles in the extremities. This is what the patient will complain. Sometimes they can have this position, but your trousers sign is what you elicit. Okay. And it can be due to ischemia or inadvertent removal of the parathyroid. Usually, the parathyroid, the hypocalcemia is lowest in the first 48 hours if it is a temporary ischemia, and then it picks up. So, how will you treat a hypocalcemia following post-thyroidectomy?
Sir, I would give the patient calcium supplementation and vitamin D.
Orally or IV? Calcium supplementation.
In
the
case if the
post-operative
patient has
status in
an
the ward.
if the patient has an acute episode, I would give it IV, sir. But maintenance, I would go for oral, sir.
What? So it is the duration, not the level of calcium, according to you. So if it's 8.2 and it's acute, you'll still give. What determines whether you give parenterally or orally? It is the severity of hypocalcemia.
Okay.
You understand? If it very rarely, if it's above 8, you'll give IV. People differ. Usually, if the patient is symptomatic and the levels are less than 8, then perhaps you will give IV. Okay. If it is more than 8, generally you will give oral. What is the type of calcium you will give? You mentioned calcium along with it. You said what will you give?
Vitamin D, sir.
Why should you give vitamin D?
Sir,
What form of vitamin D will you give?
calcitriol, sir.
Why should you give calcitriol?
Sir, it increases the absorption of calcium from in the intestine, sir.
Which one? So calcitriol increases, is it? Yes. So I am saying give cholecalciferol. Why are you not giving a normal vitamin D? What is the reason for giving calcitriol rather than your normal cholecalciferol? Okay, lack of time.
Yes.
See, your cholecalciferol is converted to 120. First, you have
25
cholecalciferol, then 25 hydroxy cholecalciferol occurs in the liver. Then 125 occurs where? Under the influence of PTH in the kidney. Here, post-thyroidectomy, your PTH is less, so that final conversion cannot take place. That is why you don't give vitamin D in that form. You give your calcitriol. So that helps in calcium absorption from the gut, because otherwise, how much ever calcium you give in severe hypocalcemia, that may be not absorbed from the gut, you need to give calcitriol. You should know the reason, because your PTH facilitates the conversion and that PTH is lacking here. Okay.
Yes, sir.
What are the other complications? How will you give parental calcium? Sorry.
Sir, 10% calcium gluconate, 10 ml over 10 minutes, sir.
Why it should be given for a period of 10 minutes?
Rapid infusion can lead to an arrhythmia and asystole, sir.
Okay. Will you give a bolus over 10 minutes or will you mix it with some fluid?
Bolus, sir.
You will give it as a bolus. I will
Bolus.
not give it as a bolus. I will always mix it with some fluid. Normally it is 5% dextrose or perhaps normal saline. Do not give with Ringer's lactate, because the calcium gluconate can cause some precipitation with Ringer's lactate. Now suppose I say instead of calcium gluconate, give calcium chloride. Will you give? That is also a parental form of calcium. Okay, lack of time. By in a rare event, when you give IV, if there is extravasation, calcium chloride can cause necrosis of tissues. So that is why calcium chloride is not preferred. It is usually given calcium gluconate. And whenever you give calcium gluconate parenterally, do not you give it over a longer period of time, 20 minutes or half an hour. You don't want to rush. Ideally, it should be given over ECG monitoring. That is an ideal condition. That is enough about hypocalcemia. What are the other complications? I think we are almost there. I think Kanagavel will be upset with us. Tell me, we have talked about hematoma, we have talked about hypocalcemia. What are the other feared complication post thyroidectomy?
You can have a
Only
nerve
one
injury,
question,
sir.
sir. If the patient has developed this hematoma, how do you treat that? And the patient is in stridor, not able to breathe. Hematoma,
You
post-operatively.
have to open the wound, sir.
Where? In the operation theater or in the ward
Yes, sir.
itself?
What?
Huh?
What, sir?
In the ward, immediately you have to remove one or two sutures and let out all the clots. And then you have to transfer the patient to the theater for emergency
Exploration.
procedure. Okay. Okay, right. Yes. Sir is asking any other complications. Recurrent laryngeal nerve injury, then parathyroid deficiency, parathyroid injury, then
How will recurrent laryngeal nerve injury present? How will you know it's recurrent laryngeal nerve injury symptomatically?
The patient will have unilateral. If it's a unilateral injury, the patient will have hoarseness of voice, sir. And bilateral, the patient may develop stridor.
how do you treat that bilateral injury of the recurrent laryngeal nerve?
You
What will
have
be
to
the
you have to go for
symptom
a
the patient will have?
you have to go for a tracheostomy.
Stridor. For all patients need tracheostomy, bilateral injury, recurrent laryngeal nerve. If it is in the adducted position only, we have to do tracheostomy. If it is in this cadaveric position, there will be space for the breathing. There is no need for tracheostomy.
Even
Am
in
I correct, sir?
unilateral, yeah, the symptoms indicate what you do. Even in unilateral injury, there are different grades of nerve injuries. Not necessarily the nerve is structurally damaged. Sometimes the nerve may be stunned functionally. That's called neuropraxia. So automatically it will occur. So during that time, it's a good practice to give a short duration of steroids so that to
Reduce the
not only reduce edema, to bring back the functional element so that it can facilitate faster healing. So neuropraxia is the one which is very common. Previously, the teaching was don't go around trying to find the nerve and it will damage it. Nowadays, the dictum is identify the nerve. One should not do a thyroidectomy without identifying the nerve. And one neuropraxia, one of the things you'll do is give steroids. There are some people who also give large dose of vitamin B12 in the hope that that will also help. There's no strong evidence, but people also give a high dose of vitamin B12. You know, that is one thing you should remember about recurrent laryngeal nerve injuries, unilateral injuries, bilateral injuries. The other symptom is not only a hoarseness of voice. People, when they have swallow, they may aspirate. You know, that is a symptom which is not told a lot in the books. When you tell them to drink fluids, they may have occasional aspiration and cough that can occur in nerve injuries. Okay, then what is the other nerve injury which we mentioned?
external laryngeal nerve injury, sir. Patient will have difficulties in reaching a higher pitch in their voice.
Okay. So, and what is the treatment for these nerve injuries in the interim? You can also give speech therapy.
Yes.
Okay, speech therapy help, especially if it's neuropraxia, it'll automatically come. If it's unilateral, generally compensated over a period of time. Okay, speech therapy and other compensates so that there is approximation. The only problem is when you have bilateral injury, that is why you'll have to be very careful. You will have to involve your friendly ENT surgeon, and there are many ways you can sort it out. I think it is beyond the scope of this lecture. We are already over short time, and I think if there is anything Dr. Prabhakar wants to add, he can add. Perhaps we can discuss on some other day other aspects. I hand it over to our coordinator and a convener, Dr. Kanagavel, for his final few words, and then perhaps we'll call it a day.
Thank
Yes,
you,
sir.
sir. I think Dr. Kanna sir and Raji Sakai sir, would you like to add something? Radha ma'am? Raji sir?
He is muted.
How do you counsel the patient for the total thyroidectomy? How do you counsel the patient for the total thyroidectomy?
Sir, firstly, I would counsel the patient that first, I would explain him the complications of the surgery, sir. Like possibility of hypocalcemia, dependence on lifelong calcium supplementations. I would also counsel him that he will have to take thyroxine supplementation throughout his life, and he has to be in he or she has to be in proper follow-up. Despite our FNAC and our radiological findings being benign, post-operatively we may find the lesion to be malignant, and we may also have to counsel the patient for the possibility of need for any RAI treatment. Then also we have to counsel them for the possibility of tracheostomy, a distal possibility of a tracheostomy.
But don't scare them with tracheostomy. Then no patient will come for thyroidectomy. You say it gently, perhaps very, very rarely. Okay.
Yes.
If you do tracheostomy, when will you remove that tracheostomy tube?
Usually you can assess for the after proper speech therapy and
even after 6 months, the patient is not having any abduction of the vocal cord. Then what is the name of the surgery? Cordotomy. Vocal cords. They will put some holes. Okay, so that the patient can breathe. There will be space between the vocal cords. Okay. Yes.
Will you do the X-ray of the neck before you plan for the total thyroidectomy?
Yes, sir. We will.
Why you do that?
Sir, it's usually for an anesthetic purpose to secure the airway for endotracheal intubation for the patient, sir. We can also
secure the. What do you mean secure the airway? You mean pre-operative evaluation of the airway? That's what you're trying to tell me.
Yes.
And how many views you will do?
2 view, AP and lateral, sir.
So why you do the AP and why you do the lateral?
AP view, we can look for any deviation of the trachea to the right or left. We can also look for cervical spondylosis, sir. Lateral view, we can look for any anteroposterior compression of the trachea, and also some signs of spondylosis can also be noted, sir.
So how does the anesthetist decide about the size of the endotracheal tube?
How many percent of patient have asymptomatic recurrent nerve palsy? Asymptomatic.
Unilateral vocal cord palsy, how many percentage of people in the normal population will have? Madam is asking.
Yes.
And why they are having that unilateral palsy, vocal cord palsy? 2 to 5% they will have, and due to diphtheria or influenza in the childhood. At that time, the patient had undergone any infection in that vocal cord, they might have gone for this vocal cord, unilateral vocal cord palsy. Why we have to know about the unilateral vocal cord palsy, even before doing surgery?
Sir, post-operatively, medico-legal.
That is the key word, medical.
One is medico-legal. 2, if you have a unilateral palsy, you will be very careful on the other side. If you roger the other side, you will end up in stridor. So that is 1 is medico-legal. 2, if you have a palsy, you will have to be extra careful and cautious when you are dealing with the nerve on the contralateral side. Okay, that is very important.
One more thing, Lavish, you said that you will explain about if it comes out, histopatho comes about malignancy. You said that I'll explain about RT. What about neck dissection in case it comes out to be compartment dissection, in case it comes out to be malignancy? Would you explain to the patient?
Yes, sir. Yes, ma'am. Yes, ma'am. Post-operatively, if we do get a thyroid report as a malignancy, we would have to re-evaluate the patient for any lymph node staging, either by an ultrasound or a CCT neck, and you have to go for a resurgery, ma'am. And when we go for a resurgery, it will definitely be difficult because of the fibrosis, and we may end up injuring the nerves later on during that surgery also.
Okay.
Most of the retrosternal goitres can be delivered through the neck incision or through the sternotomy incision.
Neck incision, sir.
99%. So what is the
Why?
indication for sternotomy in retrosternal goiter?
Sir, in primary retrosternal goiter, we may have to do a sternal incision and
Ectopic.
ectopic, and any retrosternal goiter that's uh, extending into the anterior mediastinum, then
Sorry, you got confused. Retrosternal itself, extending itself means it's in the anterior mediastinum. Not necessarily anterior. It can go either to the anterior or posterior. Number one, 9 out of 10 cases you can remove from the neck itself. Why? Blood supply comes from the neck, so you can blindly deliver it. Number one. Number two, when will you do it? Now, when it is below the aortic arch, generally you cannot remove from the neck. Okay, because it will damage the blood vessels. Number one. Number two, sometimes it can be very hard and fixed for you to put your finger or any instrument there. Number two. Number three, the 80% your retrosternal goiters go into the anterior mediastinum when it can be delivered, perhaps. When it goes into the posterior mediastinum, very unusual for it to be delivered because the structures would prevent it from delivering. Not that it cannot be delivered, but there are more chances if it goes into the posterior mediastinum, you will have to do a sternotomy. But 9 out of 10 cases, you can deliver it from the neck itself because the blood supply goes from the neck, cervical blood supply. Isolated mediastinal goiter, where you have a goiter inside with no connection to the neck, then you will need a sternotomy. Okay?
yes, sir.
One gold medal question I want to ask Lavnish. Can you answer? When you are excising the retrosternal goiter, commonly the left recurrent laryngeal nerve will be damaged or a right recurrent laryngeal nerve will be damaged. Which nerve?
Right.
No. Usually the left recurrent laryngeal nerve because it is the nerve that goes into the thoracic cavity and it turns back. The arch of aorta. It will never, this right recurrent laryngeal nerve, it never enters into the thoracic cavity because it curves around the subclavian artery. Okay?
I'll
Yes.
put the question in another way. In a non-retrosternal goiter, which nerve is more likely? If you do not know the anatomy, both nerves can be damaged. But imagining which nerve is more likely to be damaged. Now,
The
in
right
case,
side, sir. Right side, sir.
why?
Why?
The left side, since it has such a long course, it usually has in the neck, it has a straight course between the tracheoesophageal groove. Whereas in the right side, because it arches around the subclavian artery, it has a more oblique course, sir.
That is the answer. The right side is the oblique course. In the left side, it is the reasonably straightforward course along the tracheophageal groove. So if it is a cervical goiter, right has a higher chance of being damaged. Perhaps in a retrosternal goiter, you will have to be more cautious on the left nerve. If you ask me, always be cautious with all nerves.
Perioperatively on the table itself, you are seeing that, oh my God, I have injured that recurrent laryngeal nerve on the left or right side. This is a scenario. How will you manage? What you are going to do? The proximal end, distal end of the recurrent laryngeal, you are not able to, you are able to see.
Can reconstruct with the answers. If both the ends can be approximated, you can go for a primary repair, sir.
Which suture material you will use for approximation of the both ends of the recurrent laryngeal nerve? No idea. You have never come across in Madras Medical College injuries of recurrent laryngeal nerve. Your process are so great. Vicryl. Sir, what is the answer, sir? Which suture material we can use, sir?
I would use Prolene, sir.
Which Prolene, sir?
60? As fine as possible. Anything
Yes,
about
sir.
50, 60 to 70, ideally with a loop, because you cannot do without a loop. So if you are able to approximate it without tension, then you will be able to do it. Okay. Otherwise, you will have to do some sort of a graft. The common thing is the ansa cervicalis. Of course, there are
How many
other techniques.
percentage of people will not have middle thyroid veins, sir, in your exposure, sir? Vital, sir?
I think 20 to 30% may not have, sir. In fact, even the inferior thyroid is only a leash of veins. There is no single vein. In the inferior thyroid, there is no single vein. It is just a leash of veins. Middle thyroid, I have seen sometimes you'll have 2 or 3 veins also coming directly from the internal jugular. So not necessarily one, but majority you will feel one. You will find one, and your first thing is to ligate it before you deliver it, because a middle thyroid is a direct continuity. The bleeding will be a little bit more torrential if you don't ligate it before you deliver the thyroid. But generally, 8 out of 10 cases, you will find a middle thyroid, single middle thyroid. Sometimes you may have a multiple veins.
Lavnish, I want to ask one question about the inferior thyroid artery perioperatively. When the inferior thyroid artery comes and supplies the inferior pole of the thyroid gland, it comes posterior to the common carotid artery or it comes anterior to the common carotid artery. Are you able to understand my question?
Yes, sir.
Yes.
Posterior.
Yes, good. Yes, it comes posterior and it will branch out. Okay, in between these branches, the inferior laryngeal nerve, or otherwise called the recurrent laryngeal nerve, goes in between the branches. That's why you have
want to.
Yes, sir.
Yeah, I just want to highlight one thing which you said. The recurrent laryngeal nerve, the relationship of the inferior thyroid artery and the recurrent laryngeal nerve. The recurrent laryngeal nerve can go behind the twigs, in between the twigs, or in front of the branches of the inferior thyroid artery. Remember that. I think Dr. Kanagvel would like us to close. So if you have any burning issues, I'm sure it can be sorted later. Kanagvel, can we ask you to give your closing remarks, please?
Any other faculty would like to add anything, sir?
It's 10 o'clock.
It was an excellent session. Excellent session, sir. Excellent.
Thank
you
you,
for the
madam.
invite.
Thank you,
for the
madam.
invite.
Thanks a lot. And I have to say, Lavnish presented very well. I was quite
excellent,
impressed with your presentation. We are just fine tuning it. This is the place where you should and where you are allowed to make mistakes, so that this is just a dry run for your superb performance in your exam. All the best. And thank you to all my colleagues, Professor Radha Verma, Professor Rajiv, and my good, and Professor Prabhakar, and my good friend. Where is he? He has gone. Ajay Khanna sir. Hello, sir.
Thank you very much, sir. Vital, sir. Thank you very much, Professor Radha, madam. Thank you very much, Professor Kanagvel, sir, and Rajesh, sir.
And anyway, connects for his, what shall I say, consistent endeavor to do it ever since COVID. I think it requires a lot of not only enthusiasm, it requires a lot of commitment to do week after year, year after year. And I think it is a commendable effort by Dr. Kanagavel, I think, which is very difficult for any other person to emulate. Thanks,
whether he is in flight, whether he is in train, whether he is in a car, whether he is in cycle, wherever he is, he will not forget to conduct this program on every Friday.
There is no
Great,
Friday
sir.
without Kanagavel. If there's no Kanagavel, it's not a Friday.
Yes, sir, I think these are all big words. I only
these are genuine words coming from the bottom of the heart. It is not prepared. These are all impromptu speeches.
No, sir. Thank you very much. But let me also tell, this is pure and pure contribution from the faculty and students. My job is only putting pieces together. That is all. I have very limited role in handling things, because the intensity is going by the day. I find difficult for faculty and students to come in. That is a problem I'm right now facing. They say, sir, your standards are high. But anyway, thanks to all the faculty and students for making it a responsible and high standard discussion. 2 hours of thyroid, I don't think any other forum would ever permit or is feasible to have. Thank you, sir. Thank you all the faculty for giving this evening a lot of learning on thyroid. It's in fact learning for the faculty as well. And Lavnish,
Absolutely.
uh, Lavnish, thank you very much for taking
Thank
this
you.
responsibility in a
Well
short
presented.
notice. Thank you, Gayatri ma'am and Vijayalakshmi ma'am, for permitting you to present here. Kanna sir, Sahay sir, Sai sir, and Radha ma'am, Prabhakar sir, thank you very much for the
Yes,
evening.
sir.
Thank you,
Good night,
sir. Thank you
everyone.
so much.
Good night,
We sign
everyone.
off for
Standing
Thank you, sir.
the
ovation to
evening.
you,
Thank
sir.
you. Thank you. Thank you, sir. Thank you very much.
Thank you, sir.